Good morning, ladies and gentlemen. Thanks for coming to the second session of this morning's congenital sessions on VSD occlusion. So in this session, we have, let me introduce the moderators, Dr. Dora Wong from Hong Kong, and Dr. Nicholson Yam, a cardiothoracic surgeon from Hong Kong Children's Hospital. And we have also panelists discussants from Dr. Masini Alvi from Malaysia, Dr. Lun Ginseng, which is Chief of Division Service of Cardiology in Hong Kong Children's Hospital, Dr. Len Hugh Nguyen from Vietnam, and Dr. Se Yu Mei from China, and also Dr. Li Yan from China. So, and we have two speakers to deliver the debate. So the first is by Dr. Nguyen Tin Du, and he is the first speaker and topic on debate on transcatheter VSD closure should be adopted as the gold standard first-line treatment for perimembranous VSD. So Dr. Tin, I think he is a very famous interventional cardiologist. He had the first honor from Monash Medical School in 2000. He finished his years and was awarded a number of prizes during his undergrad training. And subsequent Dr. Tin Nguyen was awarded the Australian Research Scholarship and completed postgrad training in St. Vincent's Hospital. And now he continues to have a broad interest in all areas of the endoscopy, viral hepatitis, inflammatory bowel disease. And he's now providing service as serves as president of the Australian Vietnamese Health Professional Society of Victoria. And so he's have a pre-recorded talk on this topic on transcatheter VSD occlusion. So let's hear his presentations.
Good morning, everybody. I'm very happy to join IBCAS every year. This year, I would like to thank the organizer inviting me to be the speaker again. My talk today is a transcatheter VSD occlusion should be adopted as a gold standard first-line treatment for the BMVSD. It's a very interesting debate between the device closure or surgical closure for BMVSD. Just look at two pictures and you know I'm the role of the pro device closure. Surgical closure for BMVSD looks very traumatic and bloody for small baby in most of cases. But device closures is really the neat and clean procedure for BMVSD. It's really an aesthetic procedure. What are the cardiac surgeons expecting for the isolated VSD? They are trying to do some constant minimal invasive technique, and they try to do no bypass is better than bypass. And they want to reduce the duration of ventilation and hospital stay. With the such purposes, they want to do the periventricular closure for VSD without any bypass. And how about the device closure? We are doing what the surgeon expected. We are doing the minimal invasive technique. We are doing without any bypass, and we are bringing many advantages. No blood transfusion, hospital stay shorter, and no intubation, no skin external infection. And I think it will be no any debate about VSD closure if we prove that the device closure is simple and easy technique but high successful rate. The successful rate similar or higher than the surgical closure. And second one, we should prove that the device closure is safe with very low complication rates. The complication similar or lower than the surgical closure. First, I would like to mention about the successful rate between the device closure and surgical closure. And you know many the evidence show that the device closure with a very high successful rate comparative with the surgical closure. And there were systemic review and meta-analysis about the device closure and surgical closure for BMVSD in 2015 with a very large patient, more than 3,000 patients. The results of the meta-analysis show that the successful rate is similar between the device closure and surgical closure. Recently, 2020, another meta-analysis combined the 24 studies and more than 8,000 patients. They compare between the conventional surgical repair, transcatheter closure, and perventricular device closure for VSD. And the results show that the successful rate is similar between the device closure or conventional surgical repair and the perventricular device closure. And another meta-analysis for device closure for BMVSD also showed that the successful rate about 97.8% for the device closure. But I believe that the success rate should be higher in the experience interventionist. And next, I would like to mention about the complication rate. Many people worried about the device closure can increase the complication compared with the surgical closure. But what is evidence saying? Turn back to the comparison between the device closure and surgical closure in the systemic review and meta-analysis in the 2015. Regarding to the complication, the results of the meta-analysis show that the device closure and surgical closure is similar in the major complication. The heart block also the similar between the two cross device closure and surgical closure. Regarding to the residual shunt, the device closure looks better than the surgical repair. You can see the device closure with the lower rate of the residual shunt. And the valvular regurgitation, including the tracker switch valve and aortic valve, the device and the surgical repair is similar. And turn back with the big network meta-analysis comparison between the conventional surgical repair, transcatheter device closure, and perventricular device closure. And you can see the results show that the device closure with a low rate of the right bundle branch block and residual shunt compared with the surgical repair, but totally no difference between the three groups of the patients. And all the evidence says that the device closure is similar surgical repair in terms of the successful rate and the complication rate. But some things the device closure is better than surgical repair I would like to share to you. First one, you can see transcatheter closure with the angiography. You can see clearly the defect from the LV, but the surgical cannot. And you can see the structure inside the aneurysm, and you can see the opening axis, and we can see the residual shunt and involvement with the device. Here I can show you with the angiography. You can see clearly the defect, and you can see how about the left side disc of the device compared with the shunt, compared with the aortic valve, and how about the device after deployed totally inside the VSD. Another reason that makes the device closure better than surgical closure is the aneurysm. The membranous aneurysm is an advantage for transcatheter, but surgical closure, they don't care. They think it's more complicated. Normally, the transcatheter closure, we try to preserve all the tissue of the aneurysm. It means you can preserve the tricuspid valve. The surgeon, they want to cut on and later they can close. And it means they can make them more traumatic. And for the transcatheter closure, the device will go inside the aneurysm and so avoiding the aortic valve and also the conduction system. But the surgical, they cut on and they put a patch. The patch should be bigger than the shunt, and it's a high risk for AV block. And you can see in the case with a complicated aneurysm, we just put the device inside the aneurysm, and you can see the device is far from the aortic valve conduction system also, and no residual shunt. For the more difficult cases with very limited or no aortic cream, with the best view from the LV angiography, you can see we can adjust the left side disc accordingly to the aortic valve. The left side is just beneath and parallel with the aortic valve, and so not entangling with the aortic valve. For the most difficult case is the outlet VSD. We prefer to choose the device with very soft and flexible device. You can see the device can sit together and move together with the aortic valve without any aortic regurgitation. In some cases with the mild aortic regurgitation before the procedure, but when we put the suitable device with the suitable position, you can see the no aortic regurgitation after the procedure and after 6 months. Regarding to the tricuspid valve entangling, some cases the device entangle with the tricuspid valve and create a new onset TR. For avoiding TR, we change our approach from the antegrade to retrograde approach, and so we can control the right side disc of the device regarding to the tricuspid valve. Make sure that no new onset TR, and we can deploy the remain of the device. In some cases, TR is a big problem, even though the antegrade and retrograde approach, and so we change to use a single disc device and make sure that the disc in the right side is smaller than the double disc device. And for residual unction, you can see after putting the device, still residual unction, we can put a second device or third or fourth device to make sure that totally the shunt is closed. For my conclusion, transcatheter VSD closure should be the gold standard for VSD if we choose a suitable patient. It's a not too big defect but not too small baby. We should choose a suitable device in terms of the device selection, also device position also. The suitable interventionist, we need to ask the experienced interventionist to do the procedure, and all the young generation should be learned more. And just look at two pictures between the surgical repair and device closure for VSD. I think you will vote for me. Thank you very much for voting me.
Thank you very much, Dr. Tin, for your excellent presentations. And in the interest of time, are the live cases from NTU as ready, the second case? So should we switch to the live case first, and then afterwards we'll just continue debate? So can we switch to the live case from Taiwan?
Yes.
Yes. Hi, Professor Wang. Nice to see you again.
Dora, I can hear you. Yeah. And the team member is the same. Could you, Dr. Chen, can you introduce this case?
Second case is a 3-year-old boy with perimembranous trabecular type VSD. He has a history of VSD, which is found due to heart murmur noted after birth. He was presented with poor body weight gain at follow-up, and the physical examination showed a grade 3 pansystolic blowing murmur at left mid-sternal border. The chest X-ray showed a cardiomegaly with increased pulmonary infiltration. The EKG showed sinus reason with incomplete right bundle branch block. This is a cardiac echo. It revealed PT type VSD with aneurysmal transformation. Both LV to RV shunt and LV to RA shunt were noted. This is a case summary. It's a 3-year-old boy with PT type VSD, and we attempt to perform transcatheter VSD device closure. Thanks for your attention.
Thanks. Can we have the cardiac pictures, the lab pictures?
Okay. This case, we do the LV angio first. Can you show the LV angio? Can you see it? Dora?
Yes,
okay.
We can see the echoes and the angio the same simultaneously. Can you make this picture bigger so that we can see it more clearly?
Sure. And yeah,
yes.
Playback angel, yeah. The QPQS is now 1.7, and you see the multiple acid, and the VSD, the opening of VSD very large, and with multiple with aneurysm. And there's no pulmonary hypertension, but this patient has failure to thrive. And Ximin, would you talk about your echo finding.
Okay, so as we can see in the transesophageal ultrasound, we can
Professor,
see,
yeah, can we see see the echo pictures?
Echo big.
Yes, right now. Good.
okay, so now we are showing the short axis view, and we can see a very large aneurysm with multiple exit. And we just move to the long axis view, and we can see the membrane portion is all missing. So this is a very large VSD extending from inlet portion, muscular inlet portion to trabecular portion to outlet portion. The whole membranous part is missing. So, and we can see more than one exit. So the native VSD is measured as about 1 centimeter, and the multiple exit, some of the exit is measured about 4 millimeter.
But can you make the echo pictures bigger, and because it's quite small?
Bigger. Okay.
I mean, the screen, we can only see 1/3 of the screen, and the other is the angio.
Okay, so can we make the screen showing only the
echo pictures.
ultrasound now?
Yeah.
So in the
Hi,
presentation,
Lori and Chuku Wong.
yes, Tin.
I have a question.
Năm mươi bảy
Is
chu
it
chi không vậy?
the defect is inlet extension or not?
So Tin's question was, is there inlet extension of these VSD?
Yes.
Yeah. Yes.
Yeah.
Yeah, I think in
The
this view
inlet
you can see.
extension, and you see the roof of the defect is tricuspid valve, the septal leaflet of tricuspid valve. And
Yeah.
are you sure that it's strong enough for keeping the device, or it's so weak? And I saw on echocardiography, you can see a little bit TR. It means the roof of the defect is a little bit soft. And I worried if to put the device will embolize.
Yeah.
And some problem with the conduction system. What do you think?
I think this is not a good case for catheter closure. And probably we try. And probably we can anchor the left disc in the aneurysm, within the aneurysm.
Yeah.
So
And there are two things. First one is tricuspid valve entangling. The device will make the new onset TR or worsening the TR. Second one is the device stability. Maybe the device easy to embolize when you put back from the left side to the right side.
Okay. I think we try, but I think if you think this is a surgical case, maybe we try first. If there embolization, we'll call the surgeon. Is that okay?
Yeah, right. It's really very difficult case, Chuku. It's very difficult case. Yeah.
I saw the surgeons laughing. So
Hello, yeah, I'll keep my comments for later. Thank you.
yeah, thank you.
Hello, can I say something?
Yes, you.
Yeah, I just have a similar case last week in Myanmar, and I tried to using the biggest PDA device, and it's very top, but luckily the device can sit very well, and I think this case depend on the tissue of the tricuspid. Maybe you can using the PDA device. You cannot using the double disc device, because double disc device, the second disc when touching the tricuspid and make more TR. Thank you.
Yes, I actually, this is Robin. I actually agree with Hugh. And well, talking about candidacy for transcatheter occlusion, so Tin has very elegantly mentioned that there's an extension to the inlet, and you can see from that four-chamber view that it's actually an inlet extension. And secondly, it was mentioned from the presentation slides there were LV to RA shunt. I wonder if it's a true LV-RA defect, or is it just a shunting across the aneurysm? Because that would mean a hell of a difference. If it's a true LV to RA shunt, I think it would likely be a surgical case. It would be a very difficult transcatheter case. I'm not sure whether the other panelists would agree.
Robin, hello.
Hi, Masni.
Hi, thanks for inviting me. Hi, JK, how are you?
Good.
It's
Masni,
nice case that you have presented.
I need your suggestion.
Yes, what is the QPKS, PA pressure? It looks like a big VSD, as you said.
They said
Sorry?
the Q figure is 1.7 just now, is it?
I think that's probably an underestimate, yeah. But the other concern for me is that there is a big defect, as you said, and there is no margin in terms of to the aortic valve cups. So I think big defect with no margin in a small patient. Yes, I think this would be for me a surgical case. Maybe you can try implant a device. If it doesn't have any contact with the valve, then might be okay to release it. But then again, there might be the chance of embolization. But instead of implanting it and waiting it to embolize and get the surgeon retrieve it, so I would stop if this is something that I would not do in the cath lab. And number two, if you are in the lab already cannulated, maybe we can try implanting a device and then see what happens.
Okay, thank you. So we have the surgeon stand by today. So I think we'll now make a AB loop because we try to enter from the retrograde, but the sheath is stiff, so we cannot pass the sheath into RV in such a small child.
Yes.
Yeah.
So I think we go from the antegrade route. So now you can see we catch the wire. Okay.
Chuko,
Oh, good.
Chuko, it seems you use MFO device.
Yes,
right?
I'm going to use a MFO device. Tin had any, what size do you suggest?
The axis one is not so big, maybe multiple axis one, but the size of axis one is about 2 or 3, I think so. And you don't need to use a very big device, MFO, because the retention disc in the right side are also very big and will entangle with the tricuspid valve.
Sure.
And so I think in this case, we just use 6/8 is enough. It's my point.
But I choose 9.7, so I think almost similar. So I go forward with 9.7.
JK, do you intend to put the entire device inside the aneurysm?
Yeah.
Okay.
Right.
So what do you think?
I think it has
right.
to be that way because there's no margin to the aortic cups. So I think if not, you might. I think the contact to the aortic cups is very highly likely, and I don't like that to see that.
Yeah, I have an additional concern. When I look at this so-called aneurysm, the roof of the aneurysm is actually formed by the septal leaflet of the tricuspid valve wholly. So the interaction with this particular leaflet, it will be a concern. So let's see if the device sits well, then we still have to look at how the tricuspid valve behave.
Okay.
So can you guide us through what you're doing now?
Mm-hmm. So I use 9.7.
Professor Wang, can you make the CAT pictures bigger so that we can see more clearly while you advance the catheter and the device?
The device is like this, the MFO, my hand.
Yeah, I think that's a good suggestion by Dr. Dora. Maybe just focus on the fluoro life more.
Sure.
Later once you have assembled the device.
Can you show us the MFO?
Yes.
You got the camera can zoom on it and so that we can see.
The depth disc is like this, and depth disc with I don't know how to call it, a core. Then a connecting waist, then right disc. This is 9.7 with a mesh inside. Because I consider using 9.7 is that I worry about the hemolysis, so I use 9.7 because 8.6 there's no patch inside. Okay, so we started loaded.
Yeah, so for audience who are not familiar with this device, as Professor Wang mentioned, there is a cutoff where the device is knitted with mesh, which is the one exactly that Joko is using. Anything smaller than this, there is no mesh. So the device is of a smaller profile, so easier to track.
So now,
Tin and Robin, what kind of TR level would you consider acceptable post-implantation?
Sorry again?
The degree of severity of TR post-implantation that you consider acceptable, that you would leave the device.
Oh,
It should be similar before the procedure. It cannot increase the decrease of the TR.
Yes, I agree with Tin.
The TR can sometimes disappear once you implant the device because there's no more VSD, isn't it? The worry is that the TR severity increases and that keeps increasing after at follow-up.
But it's very difficult to confirm the degree TR before you release device because the device, the cable is still there.
Yes, I suppose.
Yeah,
So.
it's
Unless
very
it's a
difficult.
retrograde implantation.
Yeah, and I still want to tell our views, on this device may be better to do this. It's very hard to decide to release or not.
Yeah, I think that's one of the dilemma when we go for the anti-grade approach, where the cable is still connected and there's the tilting of the disc, which causes, well, which may introduce more TR in such a situation. But I think the beauty of the MFO, well, one of the beauty of the MFO is that the whole system, including the delivery device, the delivery system, the wire, the device, is quite soft. So there is a propensity that you can actually model around with it and see how it goes. For me, I think device interaction with the tricuspid valve would say the most. Sometimes it's really not only the degree of TR, but how it actually moves together with the tricuspid valve. At times, if it worries me, then I'd say I'll just take it out. But well, okay, Joko, back to you.
Okay, now we already advanced the sheath from venous side to aorta, then using kissing technique. Now the long sheath is now in left ventricle. So I use a pigtail as an angio. So we make an angio first to see what happened after we advance the sheath.
Okay, so if because we can't see very clearly, so am I correct that the delivery sheath is now inside the LV?
Right.
So for the panel,
we make an angio now.
Right. Okay.
Okay, 好，现在打。喂 ，angio。啊，我们在里面，赶快打。再见。Oh, there's still plenty of shunt. So I think I'm going to advance the device through the sheath to the left ventricle. Okay.
Okay. So a question to the panel. So Joko is adopting the delivery method from the LV. So in what cases would you choose this method versus actually delivering the device from aorta?
When I usually use a retrograde technique, but this case we fail for the retrograde technique because the sheath is very stiff, and we fail to advance from left ventricle to RV or to PA. So I think therefore we change to the anti-grade technique. So I think I like retrograde technique because it's easier.
Yes.
We don't need to pass make a AB loop.
Mm-hmm. So Joko, you carry on while we discuss. So what I mean is when we choose anti-grade approach, so some of us would keep the sheath inside the aorta and deploy the device, and some, like Joko, would deliver the device via the left ventricle and pull it towards. So in what sort of situation would you do aorta, or what sort of situation you would do LV? Tin?
Yeah, all device can use the technique in the ascending aorta or left ventricle deploying, except the VSD coil. I mean the coil need to deploy inside the ascending aorta. on the other devices can be deployed as any order or LV also okay, and depending on your familiar with the technique. I prefer to deploy from the ascending order, and some difficult case I should change to practice to LV, but never it doesn't matter. It's depend on your practice.
Okay, so back to the lab. So I see Joko has already deployed the device. Can you make the fluoro and echo bigger?
Yeah. I always finish. Then I have to check where is there new severe TR.
So from the echo view, it looks as if the right-sided disc is inside the RA. I'm not sure if I'm correct.
Oh, really?
Yeah.
有点担心他在 RA。
And for this type of VSD, when deploy the right side disc, you should keep the catheter very close to the septum and just push the cable. Don't put back the delivery system. The right side disc will be crossing the tricuspid valve.
Okay.
And now you should recapture the right side disc and push totally inside the RV and deploy again.
Agree.
How's the TR now on color, despite the cable still across the valve?
Okay.
Okay.
That's better.
It looks big.
Yeah. It looks very beautiful now. You can just check the TR, any new onset TR. I saw TR looks okay and similar to before procedure.
So can we now make the echo bigger?
Echo bigger.
Great.
Yeah, beautiful.
Oh, I totally satisfied with the with this. So they check the EKG. Oh, no heart block. So we make an angio again.
Is there, we have AR there or not? Or you have a catheter inside the LV, yeah?
Yeah, we have catheter inside.
Okay. All right. Maybe try to remove the catheter and check the echo again on color, because the AR is the one that worries me most.
So maybe we'll see the angio first.
Okay.
Okay.
Yep.
Then we remove the pigtail.
All right, go ahead.
Okay. Then angio. See that? There's plenty of residual shunt. But I think probably after we detach, the residual shunt will be less.
Yeah. I don't think the residuation is a big problem. It will be disappear 24 hours. It's not a big problem. And I think you should remove the catheter, the big tail, and check the echo for AR. Any AR. If no AR, you can release the device.
Okay. Then.
So can we have echo big now so that we can look at the very nice pictures?
And
so from this long axis view, it actually looks less inside the aneurysm as expected. So we were thinking about putting the entire thing deep into the aneurysm, but it looks as if it's closer to the LV margin.
Yeah, normally there no any problem with the aortic valve because the device go inside the aneurysm. It's far from the aortic valve.
Yep. So from this view, it's slightly close to the aortic valve. Can we have some color and see if there's AR?
Have the color.
No, I don't think any problem with aortic valve.
Okay, so if the panelists agree, then I am going to detach the right disc. Okay.
You think that this is in contact with the valve cups or not? Because even though there's no AR now,
in contact with the LT valve, but I think it's soft. We can tolerate this. Then
I'm not so sure, JK, in the long term, for example, say 10 years.
Long term, majority of the case going well. We up to now we don't have any case either with MFO or AD01 or AD02 had a significant AR requiring extraction.
Can we freeze frame? because on color, the cross section there on the shot is with the color. I thought there is a width, very small width of AR.
Yeah. So what do you think? I'm going to detach.
For me, it's okay, but for me, I am concerned about contact with the valve, and even if just a width of AR, I'm not happy.
Okay, but I cannot make the put another smaller size because
No, I don't think so. No, to me, it's surgery. I mean, if that is the case, for me.
Yeah.
So I'm going to.
I think the device is correct size. It's nicely implanted. I'm more worried about the long term, JK.
Yeah,
Agree.
I pray for this baby. Then I'm going to detach.
Yeah, you could if you use a 6x4.
Can you do it, JK? Do a root angiogram and see whether there is contact with the valve or not?
Okay.
The
Angio.
You could.
Yes.
If you use 6x8, maybe Manjani will not worry.
The device will not be there tomorrow.
I detach first.
I would detach first. I would do the angio first.
Then color. There's still some TR.
Is the TR a bit more than it was?
Yeah.
Just being the devil's advocate.
I think it's probably not so much. Maybe there's every two ion in this case.
I'll definitely follow this patient closely.
Yeah, sure.
How about the aortic valve, JK?
Sorry?
The aortic valve.
Aortic valve. So
is there anything?
I'm going to make an aortogram now.
Okay.
So, okay. 我踩哦。哦，哎呦，心里小心。
好，没问题。
不要打15，打12就好。14照就好。好 ，OK。哎呦，好。Okay. So. I think the aortic valve is not trapped or in close contact with the left disc. So still there maybe 1 millimeter distance. So no AR now. So I think now the problem is there's some TR.
Yeah. Not some. I think
actually there is the LV2 ion in this case. I think the shunt will get the LV2 ion will become smaller as we follow up the patient.
Yeah, but one again, I think this device may be better.
Okay, thank you.
Second this still have TR. It's not minimum. I think moderate TR.
I think the thing is that we really need to closely follow up this patient because AR and TR are real issues in this kind of VSDs.
I'm sure we'll be all interested to know how this patient do in the months or even year to come. Maybe like other conferences, we can update this particular patient in the next year's AP Cash.
Okay.
So thank you, Professor Bang. This is, again, a very, very challenging case. Nicely done. I'm sure there are lots of controversies and discussion, as in the title of the current session's debate. So I understand there is a rush in the lab because instead of 2 labs, we have only 1 this morning. So I would we'll close the live session now, and we'll go back to the debate session, and we'll see you again when this third case is ready. Thank you. Thank you very much. Very nice case.
A good case of VSD. Thank you very much.
Congratulations, JK.
Thank you.
Hello, ladies and gentlemen. We are back to our debate now. We have the first presentation the debate, and then we are going to the second part of the day. And I would like to introduce our second speaker, Dr. Sivakumar Sivalingam. Now, he is from Malaysia. He was trained in Malaysia in general surgery and then obtained a postgraduate qualification in general surgery from National University of Singapore. He then continues the training in cardiothoracic surgery at National Heart Institute in Kuala Lumpur. And subsequently, he had further training in West Midlands Deanery in UK, and then he has been a fellow of the Royal College of Surgeons of Edinburgh in cardiothoracic surgery since 2005. He is currently the senior consultant in cardiothoracic surgery and also the deputy head of cardiothoracic vascular surgery department in the National Heart Institute of Kuala Lumpur, Malaysia. Now, yes, are you ready, Dr. Sivalingam?
Yes, I am. Thank you for the kind introduction. Can I start?
Yes, please.
All right, thank you. Firstly, I would like to thank the organizing committee of the AppCash 2022 for giving me the opportunity to participate in this debate. It's so nice to see all my pediatric cardiology colleagues who I haven't seen for the last couple of years due to the pandemic, and hope to see you all again in face-to-face in the near future. So I'm going to, be the devil's advocate and, in the midst of the interventional meeting to say that the transcatheter VSD closure should not be adopted as a gold standard first-line treatment for perimembranous ventricular septal defect. So now, if you look at what are the goals that one need to achieve to close a VSD is, of course, you want to eliminate the left to right shunt. You want to avoid a heart block. You want to avoid injury to the tricuspid aortic valve. And at the end, you want to preserve the left ventricular function. Now, in the quest to achieve this, the surgeons actually, took the first step ahead when the first closure of the ventricular septal defect was performed in 1952. And then since then, the techniques have been refined over the years, and the current results have been, very good. So I really don't see why the reason that we need to have a transcatheter closure. But having said and done, in 1988, the first transcatheter occlusion was performed. And to give the credit to the interventionalists, in such a short period of time, they've taken huge strides in order to to make the results comparable or even better to the surgical results. Now, I wouldn't want to go through this. My esteemed interventional colleague had already told you about what are the problems with the surgical issues with graphical illustrations, which also is, which, I'm also not very towards it, but the problem is now we also need to look into why do we need to do a surgical correction for perimembranous ventricular septal defect closures. Now, if you look at this schematic diagram of a surgical view of a ventricular septal defect, this is a perimembranous defect, and you can see that on a surgical exposure you get a clear-cut demonstration of the anatomy and the presence of the adjacent structures, unlike what we just now saw on the live case. So to me, if you don't get a good anatomical view and perform the best closure, you are definitely bound to have some residual lesions, and that definitely the surgery eliminates. And that is the limitation of the transcatheter. Of course, in very experienced hand, like Dr. Tin, any kind of VSD is still can be closed to the to catheter, but there are limitations, especially in like the case that we saw earlier, when you have a tricuspid valve and with the LV to RA shunt, and also in smaller patients and smaller body weight, there's always a challenge to close the VSD to a transcatheter way. But having given the credit to the interventionalist over the years, the procedure has kind of, the devices have been improvised, so the complication rates have kind of come down, and the results are trying to match that of the surgical results. If you go back comparing the surgical results with the catheter results, but let's look at the surgical results from the pediatric cardiac consortium outcomes data. And in the 4,000 over patients, and if you look at, they compared the subgroup of patients who might probably have been included in the criteria of device closure. And in that particular group, the mortality with surgical closure was only 0.2%. And the complete heart block needing implantation of a pacemaker was down to 0.4%. And so these results are extremely comparable to that of these transcatheter results. And if you look at another publication recently from the Japanese cardiovascular surgery database in infants less than 1 year of age, even in such smaller infants, the mortalities are down to 0.5%, and the pacemaker implantation is down to 0.2. The highest prediction of risk factor was for those patients who are less than 4 kg weight, and these are patients probably would not fit in the criteria of a transcatheter implantation at this point in time. Around the same time, there were transcatheter device results that came off with a high and late, early and late complete heart block of 5.7%, and more complications were in the younger age patients. And similarly, the European registry for transcatheter closures in about 430 patients, they had a more comparable age group of patients, which would probably be compared with them going for surgical correction, because they included smaller patients and with smaller body weight, and with a larger size ventricular septal defects. And if you look at this particular study on the multivariate regression analysis, those patients who had lower birth weight had the highest risk of complications. And that was also concluded from a similar study from the Toronto group when they tried to close devices in patients, smaller patients with large defects. Besides the complete heart block, I think one of the recent issues that have been spoken about is the complete left bundle branch block after the device implantation. And the late onset complete left bundle branch block can lead to later systolic desynchrony. And there are patients who go into cardiac heart failure needing resynchronization therapy. So I think all these patients that have the catheter, probably we need to follow them up in a longer term to see how the results are going to be. Now, if you look at the excellent outcomes of transcatheter closures in this large size study from China, 848 patients with excellent outcomes, a heart block of only 0.23%. But if you look into this study closely, the selection of the patients are much older patients with a larger body weight. So it is definitely not comparable to that of the surgical closures of the ventricular septal defect when we compare those patients who are smaller patients with larger size defects. And also, if you look at some of these patients with the shunt size, probably they, if you look at surgical indications, we probably wouldn't have proceeded for surgery. So I think we need to look into the results in order to study them more carefully, in order to make sure absolutely certain that the transcatheter has a more advantage compared to the surgical closure. And this is also a meta-analysis which my colleague had already shown to you. And what was the conclusion on the studies from the transcatheter closure is, agreed, there is a successful device implantation rate, but there is also significant residual shunts in patients after the procedure. But in all honesty, if there is a surgical residual shunt, I do not think the cardiologists will be happy for us to leave the operating theater with a significant shunt or a significant lesion. This is something that one need to keep in mind if you want to compare the surgical outcome and the transcatheter outcome. And if you look at the pooled estimate of complete AV block, is still about 1.1%, which is definitely more than the surgical complication of AV block. And if you compare a transcatheter versus the perimembranous defect on this randomized trial, they have shown excellent outcomes on both sides, but on both arms. But the important thing is those patients who underwent the surgical closure had a higher risk of transfusion, longer procedural time, and longer hospital stay. But what is very interesting is if you look at this age group of patients that went for surgical closure, in most of the centers would probably not need blood transfusion, will definitely have a shorter ICU stay and a shorter hospital stay. So this was the last slide. In fact, Dr. Tin had shown you about the comparison between the surgical closure and the transcatheter closure. What is very evident is that the transcatheter closure patients were at the older age, but there was no difference in the comparison between the residual shunt valvular regurgitation, but definitely the patients who had the surgical closure had a longer hospital and transfusion requirement. And that is the only issue that is still debated, whether we want to avoid blood transfusion and a large scar and having a shorter recovery period. So in conclusion, there's clearly an ongoing improvement in the results of transcatheter closure. There's no doubt about it, but still there are issues, especially when it comes to smaller patients where the cardiac structures are very delicate, and it may be difficult to surmount no matter what technological advances do occur. But given the superb results reported with the surgical closure at multiple institutions in different countries, we must proceed with caution when embarking upon new indications for transcatheter closure of these defects. And this leads to a pitfall if you look at the current studies comparing the transcatheter and the surgical closure. Is like comparing apples to oranges. As it may be that the device closure patients are the smaller VSDs in older patients, and the surgical patients are smaller patients with larger defects. So until that point in time, when we really have clear-cut advantage of a transcatheter closure, the surgical closure will still fit for all ages, all sizes, all kind of defects. So the surgery will still remain the gold standard for treatment of perimembranous disease, ventricular septal defect closure in the pediatric patients, and of course in the adult patients too. Thank you very much.
Thanks for the presentation. So we're now going to the roundtable discussions about about the two topics. Can I ask a question about, if you're comparing these things, how about the cost? Have you thought about the cost of transcatheter and the surgery?
Of course, the cost of the device closer is cheaper than the surgical closer. I think in my center, the price of the device closer is just half compared with the surgical closer.
Oh, yes.
And regarding to the
less than half, if you're using a PDA device.
Yeah. Regarding to the Siva Kumar presentation, on the evidence he showed about the heart block is come from the more early the 2007. It means more than 15 years. Now we changed our practice. We don't use the first generation of ambulance device for VSD, and so the risk of the heart block almost very low. And second one is left bundle branch block. I think not only the VSD closure, but on the device closure, we should follow up very carefully. Even though very simple cases for ISD closure, after 20 years, we found some erosion. And so I think follow-up is very important for on the patient. And of course, in my presentation, I also mentioned about that the patient selection is very important. We don't try to close VSD in very small baby. It's generally it's a surgical case. And also we don't try to close very large defect. It's also the surgical case. And so for the patient more than 10 kg in the body weight, and the defect is not more than 7 mm. I mean in the right ventricle opening A6. I think it's a good case for the device closure.
Yeah, can I just add a comment to Dr. Tin's statement? I totally agree. That's why in the later presentations, I've shown the incidence of complete heart block is less in the device closure. There's no doubt about it. But of course, the issue still comes with the selection of the patients. I do not discredit the fact that there are indications to perform a transcatheter closure. Of course, if the transcatheter closure can be performed safely, there's no issue about it. But there are a lot of patients you probably cannot perform the transcatheter closure. So that's the only reason why the statement of a gold standard is still a contentious issue to be used in the setting of a transcatheter closure. Thank you.
Dr. Lin?
Yeah, I'm not a interventionist and I'm not a surgeon. Perhaps I'm more neutral to give some comment on that. I think the issue now is that both methods are effective and both methods have improved their outcome already. But the main issue is the selection of patient to which method, which is safer and avoid long-term complications. I think at this moment, I still haven't seen any article or any very dedicated guideline about what kind of patients should be go to surgery or go to transcatheter. Unlike in adult cardiology, they have already some kind of guideline. For example, for TAVI patient, what are the selection of the patient? But at this moment, I think different centers will have their different selection criteria for surgery or transcatheter closure. It is my opinion that there should be a more well-accepted guideline on selection of patient for which option of therapy. And in this era, I'm also thinking about in many cases we are having joint decision making, and I don't know whether in some of this selection of patient, apart from the opinion from the cardiologist and also the surgeon, whether the parents are being informed of the different successful rate and possible complications in selecting which options of therapy. This is just my opinion about that.
One of the comments I would like to make, especially when it comes to decision making, it also depends on how the case is presented and how the procedure is presented. If you look at the history of all the interventional procedures that have been presented, always the surgery is being painted as quite gruesome and quite invasive. So there is already a bias there many a times for the parents to choose otherwise. So I think more than presentation, I think we have to show evidence and be very truthful to the families that if there is an indication to do a surgery, it has to be surgery. And of course, if it is a clear-cut indication for transcatheter, then the transcatheter will be the best option. And I totally agree that until and unless we have certain guidelines, it's going to be very difficult to ascertain this kind of decision making. Yeah.
Dr. Wong, can I make a comment?
Yes, Masni.
Yes, thank you, Robin. Yeah, maybe the title of the debate should have been small to moderate VSDs. Then it becomes clear because I think we need not go back to that small patients, big VSDs. I think that's understandable. Secondly, about guidelines, it may be difficult because I think it has been evolving a lot in the last 5 to 10 years with new devices, and most of them are not really designed for VSD closure. But then again, people in this region has found it very useful. For example, ADO2 devices for the smaller VSDs. But I think in terms of feasibility of doing the procedure, like what has been demonstrated by Dr. Wang and his team, is excellent. But the concern to me remains the fate of the valves, the tricuspid, and especially the aortic valves. So I think that is one that requires very close surveillance. And then when the time comes that it has shown some degree where we need to do something, the problem is that it's difficult to reverse what has happened in terms of the valve vegetation. So that is something that I need to be very cautious about. It's not like it's not the same as PDA closure or ASD closure, where really there is no argument that this should be the main goal, the main procedure of choice. But with VSD, membranous VSD, I think there is still quite a lot of limitations in terms of who should be selected for this kind of closure, because my main concern is that now the heart block issue is not as prominent, but the valve issue is something that we need to be very cautious about. That is my main take, actually.
Yeah, I totally agree with both Sivakumar and Masni and Dr. Lun. The transcatheter means of doing VSD occlusion has had the quite quote-unquote disadvantage that our history is relatively short as compared with surgery. So surgery has evolved a lot, and we all learned that the surgery has its own problem to start with, and it perfected over the years, and now it's really one of the quite standard options. And VSD occlusion, as Masni has mentioned, we've gone through a lot with a lot of failures to start with a lot of heart blocks. Things have changed, and now we're using a lot of off-label devices, and different areas are using different things. We have maybe, just suffice to say, maybe up to 10 different kinds of devices that can be used for VSD occlusions. So with the coming years, I think one of the important thing is centers would have to try aligning what sort of device should be used for what sort of VSD. Other than actually picking the right patient, picking the right device, or in the future, devices can get phased out and some of them will gain more favor, and so on and so forth. So we probably need a lot of time to actually get to that point before we actually can put up evidence, because the practice itself is very different. It's actually difficult to generate hardcore evidence. Tin, you have something to say?
We are waiting for the guidelines, but most of guidelines from the US and Europeans, but they didn't do many cases VSD closure because of indications quite different with from the developing countries. And so I think we need the evidence from our countries for writing the consensus about the VSD closure, which one is suitable for device closure and which one is suitable for surgical closure. I think we need the evidence from our countries. These are my comments.
Yeah, I agree with that completely. Thanks.
May I raise a question to the surgeons? So I think Dr. Sivakumar has explained about the issue of potential progressive heart blocks in devices, which we know and which we also think that it might be a problem. So that's why we're following them follow them continuously. But as for surgical case, is there any evidence at all in terms of the long-term outcome after surgery that there will be development of these so-called adverse events, to your awareness?
To my knowledge, whatever the results that we have so far, looking into all the outcomes, and some of the papers in the long-term outcomes have not mentioned about it, because whatever you have is at the time of the correction. If you go and damage the the conduction pathway at the time of placing the patch, but subsequently I've not come across any papers showing any issues related to heart blocks in the long term. Unless if my other colleague in the surgeon in the panel can comment on that.
Dr. Lee and Dr. Yam. Dr. Lee, your mic is muted.
Turn on? Yeah.
Yep.
Dr. Robin, can you hear me?
Yes.
Okay. Thank you very much again for inviting me to participating in this meeting. As a surgeon, first of all, let me answer your question for the long-term heart block. As to my experience, I haven't seen any late onset of complete heart block or complete left bundle branch block after the surgical cases. In my center, my cardiologist presented some cases of late onset of left bundle branch block. So I think to this point of view, surgery is safer than the device closure. My comment for this issue is in every individual centers, they should have a plan collaborating with the surgeon and cardiologist, because both techniques require skillful hands. If in your center, the cardiac surgeon they have a very good results, and the cardiologists don't very comfortable of doing some difficult cases, then surgical repair of the VSD should be more considered. I think, and also I agree with Robin that we should have a joint meeting before every VSD closure or VSD repair being performed, because every part can give a suggestion that which procedure should be better for the patient. Thank you.
Dorian?
Well, you're my cardiology, so I hardly hear you report any delayed onset of heart block after VSD closure. And furthermore, I mean, from a surgical point of view, it's not a very possible thing, because we physically fix the patch at some place. If it doesn't cause heart block very early on, probably the inside will not change and will not cause any delayed heart block, unless there's unless there's in the immediate postoperative, when there's a suspicion of intermittent bundle branch block pattern. But I think the other surgeons will agree. Most of our surgical cases, most of the patients that go through our hands will have no problem with the conduction after a simple patch repair of a VSD. And in fact, it's one of our most early on trained procedure. So we have ample of experience, as shown by the second result, Dr. Sivalingam. The technique was developed very, very, very early on. Now, there's one comment I would like to make. If you look at the debate topic today, is the setting up of a the gold standard, how we define the gold standard. And for this, I would like to hear what the two speakers would like to say about how to define a gold standard. Now, without a doubt, both techniques has developed so much and improved so much over the a lot of several decades. And it's up to the time that for many patients, both techniques are technically feasible, equally good, equally okay. But then I think for setting up a gold standard, it's not just about picking the single best treatment. It also allows for a platform, an agreed platform for comparison. So I'd just like to hear what the two speakers will say in defense of your argument today. What would comprise a gold standard for this VSD repair procedure? Well, maybe I'll let Tin first. What would you think of a gold standard? Yeah, in defense of your argument today.
Yeah, my gold standard. First one is patient selection. The patient is not too small. I don't try to close for the patient under 10 kg. And the patient is 10 kg small baby. It means small LVOT, small RVOT, and very close to aortic valve and conduction system also. Second one, the defect. The defect is not too large, more than 7 mm in the right ventricle. I mean the diameter in the right ventricle. The third one, the position of the defect is not too close to the inlet extension. It means similar to the Chuku case. The case is a very challenging case, but the TR is not much, and the case can be closed. And VSD inlet extension with the TR a lot, we cannot close. And regarding for my experience, I don't worry too much about the outlet VSD. Outlet VSD, we can use the very flexible and soft device. I don't have any problems. I think Chuku One also have some experience about that outlet VSD. And that is my gold standard for device closer.
Yeah, so are you saying with all the limitations that you just mentioned, is that the time, I mean, just reading out from the debate topic, is it now the time to change the gold standard from, from surgery to transcatheter?
You haven't asked my opinion, to be honest.
Yeah.
Can I give my opinion? Can I give my?
Thank you. I mean,
what I need.
definitely. Now it's now your time to.
No, because you see, Dr. Tin has already given so many criteria. It should be this, it should be that, it should be so many things before he decides to put a device in. You as a surgeon, there is no criteria for me. I will put whatever VSD is, I will close it. So at the end of the day, which is the gold standard? The surgery is the gold standard. That's what is a gold standard, which can fit any kind of defect, any age, whatever it is, that procedure can fit all. So that is a gold standard. So now you all decide which is the gold standard. Yeah, thank you.
Yes, I think the debate topic was meant to be very provocative, as always. So we'll actually have a poll later on. That maybe I would spend a few more minutes to wait till all experts give their comments. We actually will have a poll in a few minutes' time, asking almost the same question as the debate, but I've twisted a little bit. So the poll question would be: transcatheter VSD occlusion could be adopted as the gold standard for some VSDs. That's a treatment. So
you're cheating.
I am definitely cheating. I'm always, you know me, I always do this kind of thing. So,
Yeah, you're right.
Yeah. So I'll just give it a few more minutes so that, everybody can shout their last calls, give their opinion to make a poll before I actually stand the poll on position. So Masni.
Robin, I just want to ask you yourself, Lanhu, Tin, and all the rest of the other panel, with regards to the presence of aortic valve prolapse, plus or minus a whiff of AR, would you touch that or would you send that to the surgeon?
Okay, so I'll start first because I'm probably one of the most junior VSD occlusion practitioner here. So I would not go for these sort of patients, probably, especially if there is frank prolapse. If there's a touch, what I say is the perimembranous VSD, not much prolapse, just a touch of AR, I'll probably still go ahead. But if there is already frank prolapse, then I'll probably leave it as such. I know Tim would definitely close that, but not me.
Dora or Hugh?
I don't close this. I don't touch any AR because it's a separate disease. It's not simple disease. Because if you close VSD in the prolapse keep going, and maybe in the future the patient need another surgery. For me, for VSD close, I do only the candidate for VSD closing by device is the same indication for surgery. I don't close a small VSD, and I try to close a VSD with the hemodynamic compromise, and we are very good teamwork in my center. We are discussing together. The surgeon and the interventionist sit down and working together and do the final decision. Thank you.
Dr. Abi, you asked me for my opinion right just now? Yeah. Well, recently I encountered some mainly those young girls or ladies with outlet VSD, and actually they would like to, for cosmetic reasons, they would like to avoid surgery. So I really talked to them detailedly about the pros and cons of surgery and the transcatheter closure. If they have very mild AV valve prolapse and very trivial AR or even mild, if the patient did agree for the possible long-term possibility of a more AR and thing, I will proceed for the transcatheter closure for them, especially for girls. For somehow, boys are less concerned about this for the cosmetic reason. I don't know whether it's true for the other interventionists that they encounter in other countries.
May I have comments?
Yep.
There are the difference between the prolapse of the cusp and the prolapse of the leaflet is different. The prolapse of the cusp is maybe we can see the right coronary cusp maybe prolapse with some severity, mild or moderate or severe. Of course, the severe prolapse equal prolapse of the leaflet. Only the prolapse of the cusp without the aortic regurgitation, but prolapse of the leaflet we can see the aortic regurgitation. And so my experience, I don't try to close with the prolapse of the leaflet. And so if any moderate to severe AR, we don't try. It's a surgical case. And but what the surgeon can do, we can ask Siva about that. But I think it's not easy for surgeon also repair the valve also. And just prolapse of the cusp might be moderate or mild. We can close the defect. I think you can ask Chuku Wang. He has many experience about that also. And
yeah, so back to the surgeons. Tin has just again make a very provocative comment. So about the valves, say for example, in patients with subarterial VSDs already with significant prolapse and maybe a touch of AR. So how the surgery fares in this patient? Because in the adult congenital heart studies, we know that these patients are also prone to have future aortic valve issues. In the surgeon's view, is there anything that can be done, say during the surgery, that can actually improve the outcome of the valves, so that to give the cardiologist a push to give cases to you guys?
You want me to? Can I answer? Or?
Yes, please.
Yeah. All right. Okay. So it depends on the severity of the AR. If we had, looked at our own patient population, we followed up, we don't get that many cases these days because diagnosis is much earlier. So we intervene early. So you don't see those kind of cases as much as what we do 20 years ago. But we had encountered those cases in whom they had aortic regurgitation, which are mild to moderate, right? In those cases, we have just closed the defects and we have followed up the patients, and there's been no progression of the aortic regurgitation. But the patients that have significant aortic regurgitation, the moderate to the severe variety, those patients have to be repaired. Okay. Now, the repair techniques have improved over the years. Initially we just do some leaflet interventions. And now we have new procedures such as aortic valve neocuspidization procedure, otherwise called the Ozaki operation, where you can just replace the cusp entirely. So these are options that we have in our armamentarium. But mind you, any kind of aortic valve repair is not, some may have a solution for lifetime. It depends on the severity. If you have a moderate also regurgitation, you can repair it if it's just an annular involvement. But if it's severe regurgitation involving, more than one cusp, then whatever you do will last for a period of time. But these patients need to be followed up because those patients will need reintervention in the near future. So if you have a problem, there is no issue for the repair, but the long-term outcomes still need to be addressed. And to be in this current age, we probably should not wait for that kind of significant aortic regurgitation to set in a patient with ventricular septal defect. We have to intervene much earlier than that.
Yes, I agree. For most aortic valve regurgitation secondary to VSD shunt, it is not very severe. Simply close the VSD will let the at least the aortic valve regurgitation will not progress. Most of the case, it will getting less significant. So in the recent 10 or 20 years, I haven't seen many or haven't seen any aortic valve regurgitation progress after the VSD closure. This is my opinion.
Okay, all right. So, any last comments from the panel, from the floor? Otherwise, we shall go to the poll. So let's have the polling up. I understand it's still a very provocative statement. It's somewhat blurry to just get a general feeling of what it is. I understand this would also be very skewed because most of the attendees would be either from cardiology or interventional background. So it's just an exercise of seeing how people would err on choosing. And let's start polling. We'll have a minute. 係咪開始咗啦？
開始咗㗎啦。
work 嘅。
work 嘅。
All right. I think, as mentioned, this is a bit skewed because it would definitely be a larger interventional community here as compared with surgeons. But still, there is close to 30% of audience think we might not be there yet. Okay. But I guess everybody would agree with me that it's never a single thing. Nobody can do everything, so we are always in collaboration. I'm always collaborating with Nicholson and discussing what are the best options for patients. And I agree with many of the panelists that it's always important to discuss, have your own center's protocol until we have better evidence and so on and so forth. And for the intervention community, I think it would be best if we can come together to make it larger studies, because single center alone is always difficult as compared with the volume of surgeries that our surgical counterparts are doing. We really need to come together and play this strong. So seems that our live center is ready, so may we switch to National Taiwan University. Back to you, Professor Wang. We can't. We have no audio.
Yeah.
Can you hear me?
Yes.
Okay. It's a last case. It's a 10-year-old boy with post-operative residual outlet type VSD. He has a history of coarctation and subarterial type VSD, and he received arthroplasty and VSD repair at 5 days old. However, residual VSD with small to moderate shunting was noted after operation, and there is a newly developed aortic regurgitation at the follow-up. The physical examination showed a grade 3 systolic murmur at left sternal border. This is a chest X-ray. It shows there's no cardiomegaly, and the electrocardiograph shows sinus rhythm. This is a cardiac echo. It shows a residual VSD at subpulmonary area, and there is no coarctation of aorta. Mild AR was still noted. This is a case summary. It's a 10-year-old boy with residual postoperative VSD, and we attempt to perform transcatheter VSD device closure by using MFO or ADO2. Thanks for your attention.
Okay, just for the audience, lunch will be served in room 106 to 108, starting from 12 noon to 1:45 p.m. And please go and there for lunch. There will be TV. You can just see this TV in the venue. And the next session will just follow the sessions immediate at 12:30.
So, Joko, thanks for packing this up. I know there is some last-minute change, so there's only one lab. So we have only around 15 minutes time of transmission. So we will get whatever we can. If there are things that we cannot complete, then I'll ask you to show us the results at the PM sessions. So Joko, back to you. So can you guide us through what you've been doing and what your thinking are?
Can't hear you. And can't hear.
Oh, can you hear me?
Yes.
Now,
Okay.
yes, now.
Okay, so can we go back to the classroom, the video? Professor Jun-An Chen is now doing the case with this case with audit type VSD after surgery with residual shunt.
Okay, so what is the approach for this particular case and any specific concerns?
Jun-An.
Can't hear you. Can you switch on the mic?
Can you hear me?
Yes.
Hi, I'm Jinan Chen, and this is my team. This patient is my patient. I followed up for a very long time. So now we are going to close the postoperative residual VSD, which is at the outlet septum. So now I'm trying to use the cockpit tail. You can see the live screening now. I close the VSD retrogradally. So now the guidewise, this is the 0. This is a
Can you just make the furrow bigger so we can see it more clearly, the fluoroscopy?
Okay.
Yeah, can't see clearly the fluoroscopy.
So you're going for retrograde approach, am I right?
Yes, yes. And now the guidewise is maybe at the main pulmonary artery now.
Okay, so while you're doing it now, so can I ask the panel for a subarterial VSD, whether you would prefer to go for a retrograde approach or antegrade approach, or is antegrade possible at all in this sort of situation? Tin?
Because outlet VSD, the defect is very close to the aortic valve, and so we were really worried about the aortic valve. And all the case should be due to antegrade, and so the left side this should be deployed earlier, and we make sure that no aortic regurgitation or entangling of aortic valve before we deploy the right side. This, and on the case, I think the antegrade approach is a good one.
Okay.
So Dr. Ting, are you prefer creating an AV loop, right?
Yeah, I think you should do that. And I would like to ask you to show the echo. And so which one is the outlet VSD can be closed by device or cannot? And I think echo, based on echo, we can see how prolapse of the right coricus of the aortic valve. If too severe or any aortic regurgitation, we cannot close. And can you show the echo for everybody?
Okay, can we see the T imaging? Because this is a repaired patient, so you can see a surgical patch over there. So actually, I have difficulty entering the defect using the cup pigtail, cut and pigtail. Perhaps it's very.
Can you show the long A6 view? The long A6 view can show that. Yeah. Yeah, on non-ASIC view, you see the mild or prolapse of the ICC.
Yes.
Yeah, the prolapse
Yes.
of ICC is not too much. It means the ICC not overriding onto the left ventricle septum, and no aortic regurgitation. I think it's a good case for device closure.
Okay.
Agree.
So you'll go for anti-gradely, right?
So
How
any
kind of
other
device-
panel would speak otherwise. So Tin is voting for antigrade. Personally, if I'm doing this, I would, but I don't really touch these subarterial VSDs. How about you and Masni?
Yeah, I mean, there is a bit of AR there already. Yeah. So I agree with you. I mean, if we have to do it by catheter, I would need to do it by the antigrade method because you need to see the valve doesn't touch the cups before you deploy the other disc. But anyway, I don't normally do this type of VSD for that reason. That I think the likelihood of the device contact with the cups is there, so I just don't do it in general.
All right, why don't you go ahead while we continue to discuss. So where are you now and what is the plan?
My plan is go for retrogradally. I think maybe it's save more time. It's better for broadcasting.
As always in live cases, whatever you're comfortable with, we are all just here giving comments.
But actually, I think the VSD is because it is a surgical patch, so closing this VSD is more difficult than other type 1 VSD, the native type 1 VSD. So I have difficulty closing the defect. This is a cut and pigtail.
Okay.
Yeah, I do agree with you about this case. You can do retrograde approach because the defect now, not the defect, not the hole. It looks like a tunnel, and you can control the left side this maybe easily than the native VSD.
Okay, can you make the angio bigger, the fluoroscopy, so that we can see? Can you focus on the fluoroscopy?
Can you make the fluoroscopy bigger?
Bigger.
And also the LV angiogram, if you can, let's see the defect where it lies in relation to the aorta.
There are some tips and tricks in this case. If you cross the guide wire from the LV to pulmonary artery, it looks not so difficult, but when you advance the switch and delivery system or the guiding catheter, the guide wire will be trough and we will lose everything. And I prefer to use a guiding catheter, JR guiding catheter. It's softer and easier to cross the defect. And 5 friend or 6 friend, I think we can use the device. This one, I think you can use IDU2 or the MF4 also okay. And 5 friend guiding catheter, JR catheter, I think is suitable for this case.
Okay, good.
Do you have coil, PPM coil in your left?
No.
Okay.
Okay. So is it possible to show the live fluoroscopy bigger? It's a bit difficult for the audience to know what exactly is happening. Yep, that's a bit better.
Dr. An, it's better you control the wire to the right pulmonary artery. Yeah.
Okay. So Tin, any tips and tricks from you? So it seems to be a
I
bit
think
difficult now.
I think he should try to control the wire to right membrane artery and fix the guide wire as far as possible. And in case the guiding catheter still slip to the LV, I think should change to the anti-crack approach need the IV loop.
Okay.
No, I think we can do similar like this, but we prepare the snare first in the PA. You need to put the snare in the PA to snare the guide wire when they come in. Don't try to cause of the defects by catheter first.
Yeah, I think if the support is inadequate from this floppy wire, then we might actually go
now
for
you can
it.
keep like this and snare in the
Okay.
PA. Yeah, now you can using snare.
Just a reminder to the audience and to the National Taiwan University, we have 5 minutes of airtime left. So no rush. As mentioned, I understand the difficulty today. So you can finish off the case with your pace, and then hopefully Professor Wang can give us an update of how the case went through at the end, and we'll discuss it in the afternoon session as well. So go ahead to do whatever you can, and we have 5 more minutes with you. Thank you. All right, so it seems that we are going for the snare.
Yes.
All right, okay.
Yes. I think the support of retrograde is not good. Yeah.
So it's for me, for the right heart cath, I usually use a balloon tip catheter because I'm always worried that there would be things would get caught in the tricuspid valve. I'm not sure if other operators would do the same, or you're not very concerned.
Yeah, that is a concern, definitely, Robin. But I don't use it all the time. If it gets caught, then only I use that technique. But otherwise, not as a routine.
Yeah.
But when you make the IV loop, if the IV loop looks straight, it means no tricuspid valve entangling.
Agree.
And even though you use any catheter.
Yeah, it doesn't happen all the time, so that's why I don't use it as.
Yeah, sure. All right, so we see the snare, and we'll see how easy that would be.
Dr. Jackie Wang, are you still there? I mean, this VSD, is it dehiscence or it's been there from the start? That is a residual shunt.
So is this from the Taiwan team, is this a dehiscence, or is it all along there, the residual VSD? All right, it seems that we have the wire snared.
I think the curve is okay.
Yeah, it looks nice.
Yeah, it looks good.
What do you think?
Yep, it looks good.
I think it's okay.
So 他只有 opinion about the size of MFO.
Okay, so from the angio and from the echo, what was the size? And the panel may suggest the size, and we might have to go. So can you show us the angio and the echo again, looking at the sizes of the VSD?
Anh Lâm anh đã gọi cho anh chưa? Thuốc ca ở trong này chưa?
Có rồi.
Cái gì tóm lại là vẫn từ Sài Gòn vào Bình Định xong rồi về Hạc đi Sùa luôn.
Về nhà được một hôm mà.
So from this measurement is around 3.9 millimeters.
Yeah.
Còn sáng 9 làm việc ở đây.
I think if you use a MF4 7 by 5, I think it's okay.
Tốt nhất là khám.
Or 6 by 4.
Yeah, I would be erring to go for the 6.4 in light of the proximity to aortic valve. Well, but again, yes, I'm probably not going to do this anyway to start
Because this
with.
is a post-operative
Did you deploy from the RV or from the LV or from the aorta tin all the time?
Tin, would you deploy from the aorta or from the LV in this case?
Should be aorta. It should be aorta is safer. And the left side disc and the waist should be deployed in the ascending aorta and pull back through the aortic valve, because the MF4 and IDU2 is very soft and flexible, and it's very easy to cross in the aortic valve without any entanglement.
I thought the chances of trapping the cups is not higher if you go from the aorta rather than from the LV. I mean, I don't do it, but I would do it from the apex of the LV and then bring up to the.
For the ideal one, the stiff and bigger device is a big problem for trapping aortic valve trapping. But the ideal 2 or MF4, the device soft and very flexible, and no problem for the aortic valve trapping.
Sorry, we have the airtime is up today, so we'll keep you posted about the updates about these cases maybe in the afternoon.
Yes, thank you very much for joining the session. I'd like to thank all the panelists, the operators, and thank for Professor Joko Wang's team. I know you're working very hard on a Saturday morning, and we'll hear from you in the afternoon. Thank you very much for joining.
Thank you very much.
Thank you.